move on to Samantha. Samantha, you can pull up your slides.
Can everyone see just the presentation, not my notes?
Yes.
Okay, perfect. Thanks everyone for joining us today and listening to these awesome presentations. My name is Samantha Skinner and I'm a PhD candidate in the Department of Sociology at Western University. The research I'm presenting today is part of my larger dissertation project that examines the associations between informal caregiving and health outcomes. So first, let's define an informal caregiver. An informal caregiver is someone who provides unpaid help to another person in one or more areas of activities of daily living or instrumental activities of daily living. In 2018, 24% of Canadians aged 15 and older provided some form of help or care to a family member, friend, or neighbor with a chronic condition, disability, or problem related to aging. The number of individuals who will need care is expected to increase as the baby boomer generation continues to age, life expectancy of people with disabilities rises, and chronic diseases become more prevalent. Caregivers are an essential part of our healthcare system as they provide a substantial amount of private in-home care that are costly to administer formally, and thus save the government billions of dollars annually in formal healthcare costs. We do know, however, that caregiving can negatively impact caregiver health and well-being. There's some studies out there that show that there is a positive association between informal caregiving and an increased risk for depression, anxiety, lower life satisfaction, sleep deprivation, and mobility issues. So caregivers feel that they have unmet caregiving support needs and wish that they had more support. However, there are currently no national level caregiving policy frameworks or standards to support informal caregivers. Instead, what we have is a fragmented and patchwork system of policies and supports provided through provincial and municipal governments, all of which have their own priorities, standards, and target populations. More, the majority of these services provided are aimed at care receivers themselves. And so the benefit to caregivers is indirect if there's any benefit at all. We need to maintain a healthy caregiving population as it is vital to the success of private in-home care, helping care receivers stay in their communities and mitigating the extensive financial costs and strains on our healthcare systems. If informal caregivers experience negative health and well-being outcomes, their capacity to provide care could be diminished, and this could have negative consequences for the caregivers, care receivers, and our healthcare structures. This is particularly important in light of the COVID-19 pandemic, as the government debt and spending on formal healthcare services and costs is at an all-time rise, and we are likely to end up in an era of austerity. Further, concerns over the safety of long-term care facilities that arose during the pandemic may deter individuals from choosing formal care settings, thus increasing the demands on caregivers themselves. It is therefore imperative that individuals whom are most at risk for health consequences as a result of their caregiving context are identified in order to prevent negative health outcomes and maintain a healthy and successful caregiving population. But if we want to have a comprehensive and effective caregiver policies and supports, we really do need to understand what the landscape of caregiving and caregiving context looks like. But this is really hard to do, especially at a nationwide level. Caregivers are very diverse. They're not a homogeneous group. They have multiple caregiving contexts and experiences, and they differ from each other in many ways. There is limited Canadian population-based research, although there is some good research that examines lots of contexts at once, because it is really hard to include multiple contexts in statistical analysis. So to overcome this challenge, I had 3 research questions and objectives. Can we identify groups of caregivers based on multiple caregiving contexts? And if so, how are these caregiver types represented within our population? And are these caregiver types, do they differ on different health outcomes? To address these research questions, I used the cross-sectional general social survey of 2018, which was a caregiving and care receiving cycle. Of this data set, I restricted my data to just informal caregivers providing about 2 hours of care a week, which represents about 6.5 million Canadians. To identify caregivers based on a myriad of caregiving context, I use latent class analysis. Latent class analysis is considered a person-centered approach and a statistical procedure that identifies qualitatively different subgroups of people based on a set of observed characteristics. It is considered, and latent class analysis can then identify the probability of your sample population ending up in the different subgroups based on how they respond to your indicator variables. So here's a list of my indicator variables, all 11 of which were binary, and they were all informed by a stress process framework. We can discuss these more in detail in the question period if you would like. My optimal latent class model produced 6 caregiving classes or categories, which can be defined in 2 broad groups of casual caregivers, which had a high probability of providing care to a parent, providing less than 20 hours of care a week, and not living with their care receiver. Intensive caregivers, on the other hand, had a high probability of performing more than 20 hours a week, lived with their care receiver, and had very little choice in whether they participated in the caregiving or not. Further, we can categorize these based on whether caregivers were unstrained, and these had a low probability of answering yes to the stressor indicators. Whether they were moderately strained, where some of the stressor indicators were yes, or strained, where participants had a high probability of responding yes for all stressor indicators. So this is what the distribution of the membership probability looks like in my sample. You'll notice that about 50% of all caregivers are unstrained, where half of those are intensive caregivers and the other half are casual. You'll also note that about 25% here in the center are strained caregivers, where 8% are intensive caregivers and 17% are casual caregivers. So the next step of my analysis was that I wanted to use these caregiver classifications to predict health outcomes. I ran 3 logistic regression models, each representing a different dependent variable of self-rated mental health, self-rated physical health, and a disability severity score. I also controlled for all your standard demographic covariates. And Mark, these are the predicted probabilities for interpretation. So as you'll see, strained casual caregivers had the highest probability of reporting poor self-rated mental health, followed by moderately strained casual caregivers. Strained casual caregivers, again, had the highest probability at just over 25% of reporting poor physical health, followed again by moderately strained caregivers. And last, again, strained casual caregivers had the highest probability of falling into a severe disability category versus all other groups, and moderately strained casual caregivers had the second highest probability. So what are the takeaways of this research? Well, casual caregivers make up over 50% of our caregiving population and are also at a high risk or higher risk for negative health outcomes than other caregivers. Casual caregivers may be an overlooked group in research because we often want to focus on intensive caregivers, as it is assumed that they're doing the most stressful work. And because casual caregivers may be overlooked in research, they're also likely falling through the cracks and being overlooked or not qualifying for policies, criteria, targets, and supports. Casual caregivers are probably the ones that are considered part of the sandwich generation. They're the caregivers balancing social roles, work, childcare, and informal caregiving. Therefore, future research for policy development needs to include these caregivers when assessing support needs. More, National policies should address service gaps in provincial and municipal governments. So for example, if certain casual caregivers are not getting services at a provincial or municipal level, national caregiving policies should be able to pick up that slack. Additionally, this research really highlights the diversity in the caregiving experience and indicates that policies will need to be flexible to caregiver needs. A one-size-fits-all approach may not work. For example, national policies could do direct payments where caregivers are allowed to decide how they use financial supports to mitigate their stress. Because what a moderately strained caregiver might face as stressful and need supports with may not be the same as a strained casual caregiver or even a strained intensive caregiver. A more concrete example would be the Canadian Caregiver Credit, which is currently a non-refundable tax credit for health for caregiving costs. If this was refundable, this would be able to help both intensive caregivers and casual caregivers. Yes, and supplement other. I blanked. Sorry. Other caregiving stressors. And of course, we really need to consider what the caregiving landscape looks like. Because again, this research was in 2018. We really need to consider what the landscape looks like now, post-COVID-19 and during this era, because these caregiving categories may have changed and the context in which caregiving takes place may also have changed. Thank you.
Thank you, Samantha. And to start off our final Q&A round of the day is Marian. Marian, you're muted. We can't hear you.
Yes. Do you mind if I come a little later?
Sounds good.
I need to think of it.
Sounds good. So Hugh?
I was wondering, I didn't have a good look at obviously at your data set, but was there a type of like patient conditions that that could be important in this? Like, are certain conditions more likely to lead to a strained informal caregiver, like Alzheimer's? Was your data cut like that, or did it have those type of data points in it?
Yeah, so this analysis that I did here is the third chapter of my dissertation. So we did assess those things in the earlier chapters. And what we found is, and this research has been done using other data sets, but yeah, so dementia caregivers are a large portion of caregiving, and a lot of research does indicate that dementia caregivers are very stressed because of the intensity of the care. In my research, I found that conditions don't matter as much. What matters is more the context. So someone could have a dementia caregiver, or sorry, a dementia care receiver, but only does like 3 hours of care a week. So they're not really stressed. So including things like the hours of care, the duration of care, like so how many years, how many tasks they do a day, all of those kind of actually capture those other aspects of the condition of the care receiver better than the actual condition itself. If that makes sense.
Yes, it does. Thank you very much.
Thank you. Mark?
Yeah, nice presentation, Samantha. Glad to see predicted probabilities for sure. So just wondering if you did any work on, or if you could comment, maybe it was in an earlier chapter in your dissertation, but about like who are these strained caregivers? And I'm just thinking about targeting for policy, like things like provincial variation, even, age groups, gender. Are there specific groups, immigrants, non-immigrants? Are there specific groups that we need to be thinking about, or that policymakers need to be thinking about?
Yeah, so I have started this part of the analysis. Unfortunately, because of the way my class is separated, they're so well separated, I couldn't take out these item probabilities because the cell sizes are too small in the data, but I can speak to it a little bit. So the intensive caregivers, in both cases, in my previous chapter, I looked at this and it's really hard. I wasn't finding any specific demographic variables that really predicted intensity. So I thought there would be a gender interaction, and there really isn't. So females, although they do more hours of care, weren't more likely to score higher on these stressor variables than males necessarily. So for the, I'm trying to think how I can word this. For the intensive caregivers, their categories, they're the ones, so they're usually spousal caregivers and they're living with their care recipient, but they're also sometimes providing care for their parents. But again, that co-resident piece seemed to be really key in doing more than 20 hours. And again, the choice in care really seemed to predict. So if they weren't, like the casual caregivers typically had a choice in whether they wanted to care. And so the ones that were caring were kind of opting into their caregiving. And for some reason, that seems to make a bit of a difference. I'm not sure, is this answering your question?
Yeah, I mean, partially. There's other dimensions, of course, provincial differences. I'm just thinking about, you know, from the policymaker's perspective, what might be informative. Yeah. Or more informative, I guess.
Definitely, it follows along the trend of those providing more hours of care. I looked at socioeconomic status, and I think there is some relation. So again, people with lower SES are more impacted negatively and are more likely to experience strains. Whether they're more likely to be doing intensive care, it's less so. It's more whether if they're available or not. So if they're working versus not working kind of thing.
Okay, great. Thank you.
Okay. Ramona.
I'm curious about home care. And the reason why I'm curious about home care is I'm working on a project that's looking at sort of more of a gig economy, and casual caregivers are really important in terms of that divide between who provides formal care and who provides informal care. Could you speak to sort of this notion of the need for care, access to care, and then utilization of other services like home care, and what you think the policy imperative is as far as home care is concerned to support these informal caregivers?
Yeah, so my understanding, and I come from my area of research, I actually was like a support and home care worker for people with disabilities for quite a few years. And my understanding is that the need for in-home care is quite high. However, the waiting lists are very long, and these are in-home care typically is at a provincial level and sometimes a municipal level. And where I think you're seeing some of these casual intensive caregivers having worse health outcomes is because they're likely not qualifying for these intensive cares these care programs because their care receiver and the demands of the care receiver are probably not intense enough to meet that criteria threshold. So in terms of policy, I think there either needs to be a way to supplement some of that in-home care for casual caregivers, whether even if it's just a couple hours versus some, intensive caregivers might need a nurse coming in every night. So maybe it's a nurse coming in only every other night to give the casual caregivers a break. But I think in terms of policy, there's this whole group of caregivers that are kind of falling through the cracks and that we need to focus more on because we don't assume that they're stressed because they're only doing it part-time, right?
Thank you.
Okay, Jeremy. You're muted.
The mute button. Samantha, I'm going to ask you the question that I personally do not like to get asked, so please respect my apology.
Okay.
What about other jurisdictions? How is there any evidence to suggest, because if I'm a policymaker, often we get asked as people bringing stuff like this, what goes on in other jurisdictions? What evidence can you show me where this has had a tangible effect on health of caregivers, where another jurisdiction did this, or where they did something that, because I think of with caregivers, what are the opportunity costs? What are the things that the caregivers themselves are not doing or able to do perhaps with their careers? You mentioned sandwich generation, things they can't do. So what kind of evidence is there out there to suggest that doing something like you suggest, like with a tax credit, is demonstrably good?
Yeah, so I was actually reading up on this when I was trying to think of different ways that we could use, that we could have some policy interventions. And one thing I noticed is, and I know a lot about like more Ontario policy than other jurisdictions, but in Ontario, care receivers or caregivers receive funding that they can use for respite care for their care receiver, right? So their care receiver you can use that money to hire people to take care of your care receiver. In Ontario, you can't use that direct funding to hire a family member. So let's say you are a mother and you have an adult disabled child that needs full-time care. You can't use that care to pay the mother to provide that care, and thus giving an income. So what happens is a lot of times there's an opportunity cost for women, and we've kind of seen this with the pandemic, where women end up cutting back on their employment. I know this again, just anecdotally from people I know in the state of Minnesota, where they can pay their family members to provide that care. And that takes a huge financial strain off of their family, because now they are doing that work and providing care for someone, but they're also being paid. So those financial costs aren't the same. And we know that the financial strain on caregivers can lead to negative health consequences, right? Just like anyone who's financially strained is more stressed and more likely to have poor mental health.
Okay, thank you.
Okay, and last but not least, Marion.
Hi, I have a couple of questions. One is, you've spoken about caregiving provided by the government, or at least I think in response to Ramona's question. But is there, in fact, a question, a variable, in fact, that you've got indicating whether or not there is a paid caregiver coming in as well as these casual? Yes.
Yes, so actually it's not in this presentation, but I did group membership probabilities by whether or not the caregivers received formal care, so paid help, and those membership probabilities do change, right? So it does matter. So there is that variable, and that is sort of the next step of the analysis, is including those covariates to see if there's any interactions that change the likelihood of being involved, like ending up in these caregiving classes, but also if it changes the odds of different health outcomes. There is also a variable for people who have other informal supports. So and this was an indicator variable I did try to include in like class analysis. Not all of these caregivers surveyed are primary caregivers. Some of them are secondary caregivers, and it just so happened that they're the ones that did the interview. So some of them have other people also taking care of their care receiver. And so that is likely going to change some of these results too. And the next step is to include that in the analysis.
Okay, thanks.
I made that mistake now. Okay, so thank you so much, finalists, for all of your presentations.